Assalamu alaikum. Today we will discuss about a very important and a very common issue, that is GERD or gastroesophageal reflux disease. This is chapter number 9 of Irfan Masood or internal medicine, that is gastroenterology, and the first topic I'm going to discuss from gastroenterology is GERD. You all must have heard about this disease and you must be having some knowledge about it as well, but let's just discuss about it in the perspective of internal medicine. We will discuss about its pathogenesis, risk factors, clinical features, diagnosis, treatment, and complications as well. So as its name indicates, after listening its name that it is gastroesophageal reflux disease, it must come in your mind that there is reflux of something. But reflux of what? Reflux of something, uh, here it is gastroesophageal, so here is the reflux of gastric contents or gastric juice or gastric acid mainly. Where is the gastric acid present? Into the stomach. Gastro here means stomach, so from the stomach there is reflux of the gastric acid or gastric contents into the esophagus, and mainly it is lower esophagus. Lower esophagus is involved here, and it is also called reflux esophagitis, as its name has also been its definition has also been written here, that it is reflux of gastric contents into the lower esophagus, and it results into the esophageal irritation and inflammation, as it has written in the very start that it causes or it results in esophageal irritation and inflammation. So let's just discuss about its complications first. Just consider that this is the lower esophagus and this is the stomach of the person, any person. And normally, columnar epithelium is present in the stomach, but in the lower portion of the esophagus there is stratified squamous epithelium. And if we talk about the color of the mucosa or color of the lining, then it is somewhat reddish or brownish color in the stomach, but it is whitish color. It is somewhat whitish color in the lower portion of the esophagus. So what will happen, that the mm, gastric juice or gastric contents from the stomach will reflux back here, and what it will cause, as a process is this process is happening again and again and repeatedly, and it is continuous. So what will happen, there will be some pathology obviously in the lower portion of the esophagus. If you continue to interfere in someone's work, or if you continue to interfere with the natural process, then there will be some reaction as well. A reaction has a reaction, as this action is against the nature, so there will be some reaction in the lower esophagus, as it will cause what, it will cause inflammatory process. It will initiate inflammatory process at that site, and it will cause your esophagitis. And you must have read it already that in the case of inflammation, as it is also protective mechanism, wherever there is inflammation at that site, healing also starts, right? At that site, what happens, healing also starts. Healing process occurs, and if that healing fails, for example, then even ulcer can occur. And if this healing process is repeated and it occurs again and again, then what will happen, here can occur, a fibrous tissue will form here. Just suppose that this process is occurring again and again. Just suppose that this reflux is occurring again and again, inflammation is occurring again and again, and the healing process is continuous, and it goes on and goes on, and due to which what occur, it will cause the formation of a it will just cause the formation of a fibrous tissue in the lower portion of the esophagus. And whenever there is fibrous tissue formation, like there is somewhat fibrous tissue will form, so it will cause the stricture formation here. It will cause the narrowing of the lower portion of the esophagus. There is no need to cram the complications. Just remember that number one complication is esophagitis. Number two is here ulcer can form. Number three, due to repeated healing and a repeated fibrous tissue formation, there can be structure formation, right? And moreover, which complications can occur, these complications are written over here, that just consider that this was the lower portion of the esophagus. Okay, around it there are some vessels, right? There are some vessels around the lower portion of the esophagus, and due to this procedure, due to that inflammation or irritation or something that is occurring over here, what will happen, that these vessels can also rupture, due to which there can be iron deficiency anemia, right? We have discussed the structure, we have discussed the esophagitis. And number three thing is that the normally I said before that there is columnar epithelium in the stomach, but there is stratified squamous epithelium in the lower portion of the esophagus. And the gastric juice will cause no damage to the mucosa of the stomach, right? As our body or our tissues, uh, if they are exposed repeatedly to the acid, they will be damaged. But it is a natural phenomena, or due to some other mechanisms that I'm not going to discuss here, due to some other mechanisms, and this acid will not cause any type of damage to this stomach. But if that acid goes at some other place, like into your oral cavity, like if it goes into the lower esophagus, then it will cause some reactions there. And even if it is long term, and if you don't treat it, you ignore it, then what will happen? Barrett's esophagus can occur. Barrett's esophagus means that the lower portion of esophagus, stratified squamous epithelium will be changed into the columnar epithelium. So it is one of the complications. And Barrett's esophagus also changes into the adenocarcinoma in most of the cases. So it is a very alarming sign. You have to pay attention to this. So that was all. These were the complications of the esophagus. So let's just go towards its pathogenesis. I have divided the pathogenesis as well as the risk factors. I will discuss it in one section. I have divided the pathogenesis into three portions. That what are the reasons due to which GERD occur? Number one is that there is lower esophageal sphincter relaxation. Like this is the esophagus, and just here before starting stomach, there is a sphincter, that is lower esophageal sphincter. So if there is any relaxation or incompetent lower esophageal sphincter, that is also called LES, due to which what will happen? GERD can happen. And I will also tell the risk factors due to which this lower esophageal sphincter tone is reduced. Number two factor is that there is increased HCl production, like there is increased HCl or increased gastric acid production. And number three factor here is due to increased intra-abdominal pressure. Like if this is someone's abdomen, here the pressure is increased. Due to this increased pressure, even or due to the delayed gastric emptying, what will happen? It can even cause the GERD. So GERD can also occur if there is increased intra-abdominal pressure. So which risk factors are responsible for causing the increased intra-abdominal or intra-gastric pressure? That are obesity, that is pregnancy, that is obesity. Or if you have taken increased meals, that doesn't increase intra-abdominal pressure as such. We can say that increased intra-abdominal pressure or increased intra-gastric pressure can cause GERD. So, among increased intra-abdominal pressure, increased intragastric pressure, there are some risk factors like obesity, like pregnancy, like increased meals. That is actually physiological GERD. I will tell it to you in the later discussion. And after that comes that which things causes lower esophageal sphincter relaxation or its tone is reduced. That can be remembered by mnemonic, though it is very easy, but you can remember it by mnemonic. SAD, caffeine. Okay, as for smoking, A for alcohol, D for drinking, and caffeine for caffeine. Sad caffeine can cause lower esophageal sphincter relaxation. Number third thing I said to you was that there can be increased HCl production, and increased HCl production can occur in which situations? Like if there is Zollinger or Zollinger, whatever it is, Allison syndrome, or if someone is alcoholic, or if someone is a smoker, or if someone is using NSAID. So all of these factors are responsible for causing increased gastric acid or increased HCl production, and it is also ultimately associated with GERD. Now, let's just discuss about the common symptoms that can occur in the case of the GERD. There can be chest pain, heartburn, there can be painful burning sensations in the throat or chest. There can be dysphagia, or there can be sour taste in the mouth, wheezing, asthma, chronic coughing, and difficulty breathing. Why it occurs? I'm sorry, I have not mentioned it in the complications. I must have mentioned it. Just suppose that this is the esophagus of the person, and you know that in front of the esophagus there is larynx or trachea, etc., or airways. So if aspiration of that gastric acid, or due to the GERD, if there is aspiration into this larynx, what can happen? There can be hoarseness of voice, there can be cough, there can be irritation, or even there can be the blockage of the air passages, or difficulty in breathing, coughing, wheezing, asthma. Wheezing asthma will occur when aspiration will occur into the lower bronchi or bronchus, major bronchus, etc. But if it is just limited to the larynx, then what will happen? There will be hoarseness of the voice, there can be cough, there can be difficulty in breathing, etc. It is also a complication. Okay, just mention it in the complications. Okay, next one is excessively salivating, that is water brush sign, because whenever reflux occur, there can also be the reflux of the gastric juice into the oral cavity. So due to which salivation is increased, as saliva is alkaline in pH. So in order to neutralize that gastric acid that is acidic in nature, salivation starts, due to which alkaline saliva is produced. Tooth erosion can occur in the long term cases, belching can occur. पेशेंट आपके पास कैसे आएगा? वो आपको चेस्ट पेन का बताएगा, हार्ट बर्न का बताएगा, आपको बताएगा खाने में मसला होता है, एंड इवन देयर कैन बी सम अलार्मिंग सिम्टम्स एज वेल. व्हाट आर द अलार्मिंग सिम्टम्स? यू मस्ट नो अबाउट, इट इज़ नॉट मेंशनड इन योर बुक, but you must know about the alarming symptoms, and alarming symptoms include the dysphagia or dinophagia, vomiting why occurs, as I have told you before, that due to the rupture of the vessels around the esophagus, there can be GIT bleeding. It is also alarming sign. Vomiting is also alarming sign due to sudden weight loss. Due to sudden or chronic blood loss. Not sudden, it is chronic blood loss. Iron deficiency anemia can also occur. Weight loss can also occur. Early satiety can also occur. Patient कहेगा कि मुझे भूख ज़्यादा नहीं लगती, जल्दी मेरा पेट भर जाता है. ठीक है, तो ये सारी चीज़ें हमारे पास क्या है, ये अलार्मिंग साइंस के अंदर आती हैं. और जब अलार्मिंग साइंस आ जाए तब हमें एंडोस्कोपी करनी पड़ती है पेशेंट की. आई होप सो दिस विल बी क्लियर. ये आप देख सकते हैं, यू कैन सी दैट these are the teeth of the person who is suffering from the GERD. This is mainly due to the acid reflux into the oral cavity. Okay, now let's just discuss about its diagnosis. It is very important. As patient presents with, patient आके ये कहता है कि मुझे हार्ट बर्न है, तो आप ये चेस्ट पेन है उसको, तो you will consider that maybe he is suffering from any heart related issue. So you first of all do what? You do ECG, and or even you can check the troponin levels. If that ECG is normal, or if troponin levels are normal, then it means that the person is not suffering from any heart related issue. Then you just consider that the person is suffering from the GERD. And like if ECG is normal, troponin levels are normal, then you just start PPI trial. Proton pump inhibitors, you just start empirical treatment, that is PPIs. And if there are no improved symptoms, like patient is not improving at all, if it improves, then we just continue, we maintain this dose for almost 8 weeks, and after that we will discontinue the treatment. But if there is no impaired symptoms, or if alarming symptoms come like odynophagia, dysphagia, or any GIT bleeding or hemorrhage, etc., and then what you will do? You will do esophagogastroduodenoscopy, or simply you can say that you will do endoscopy. Okay, and if there are no improved symptoms, like if it is normal, then it's okay. Then just what you will do in that case? Then you will again start that PPI. But if there are no improved symptoms like PPI, still use there is endoscopy is normal. Okay, and you again start PPI, but again there are no improved symptoms, then what you will have to do? You will have to do esophageal manometry and 24-hour pH monitoring. Right here it is written in your book as well. You can see from here that endoscopy is the investigation of choice, but we will not just do endoscopy in the patient who is just coming in our OPD a few hours ago, and we will just do his endoscopy. No, that is not the investigation of, or that is not the first investigation we will do, though it is investigation of choice in the GERD. Okay, what you will do? You will do ECG, troponin, check troponin levels. If these are normal, then you will start PPIs, and if the patient improves or symptoms improve, then you will continue it for the rest 8 weeks. And after that, if there is no improvement, or if alarming signs come, then you will do this endoscopy. After that, you will do endoscopy. What endoscopy will tell you? If there is any stricture, if there is any carcinoma, if there is any narrowing, or if there is any obstruction in the esophagus, that can be easily ruled out by this endoscopy. And after that, If there is no carcinoma, there is no malignancy, there is no stricture, there is no narrowing of the esophagus, and your endoscopy, your patient's endoscopy is normal, but still there are no improved symptoms with the PPI, then you will do what? Then you will go towards the esophageal manometry or 24-hour pH monitoring. Esophageal manometry is mainly used to check the it is mainly used to check the lower esophageal sphincter pressure. Like in the GERD, the patient obviously has lower esophageal sphincter pressure. And in the case of 24-hour pH monitoring, you will do what? I will tell it to you. The two processes, about the two processes. This is esophageal manometry. You can see from here that lubricated catheter is inserted through the nose and guided down the stomach. Catheter tapped in place while you lie on the side or patient lies on the side. Doctor measures the lower esophageal sphincter pressure. Okay, and lower esophageal sphincter pressure is obviously lower in the case of GERD. And if the patient is not suffering from the GERD, then it will be normal. And after that, you will do 24-hour esophageal pH monitoring. Like you do what? You just pass the probe into the patient. First of all, you pass the NG tube. After that, you pass the probe into the patient. And this probe is just placed in the lower portion of the esophagus, and you send the patient to his or her house. आप उसको बोलते हो कि जाओ घर चले जाओ, अपना नॉर्मल काम करो, जो भी आप करते हो. It is ambulatory 24-hour pH monitoring. And after 24 hour, just patient comes to you and you check the on this pH recorder, you check the pH of the patient. pH of the mainly lower esophagus. As lower esophagus is not acidic, it should not be acidic at all in the normal patients. But in the case of the patient suffering from the GERD, the pressure in the lower esophagus, even it is, I'm sorry, not pressure, pH in the lower esophagus will also be lowered in that patient. Just a graph here where you can see that 24-hour pH monitoring of the patient is seen. Okay, you can say that this is almost normal, though it is not normal. Just consider for the example that this is normal. If this line is just at 4, it should be just above that pH. If 4 is somewhat looks like acidic. If it is, just suppose that if it is, this line is at the 6, and these peaks are just 1 or 2 or 3 peaks are just below it. दो तीन दफ़ा तो दिन में पेशेंट ने वैसे खाना खाया होगा ना, 2 or 3 times, and it is a normal meal that a patient takes every day. So 2 to 3 peaks just below this baseline will not indicate that it is GERD. But if it is somewhat like this, 1, 2, 3, 4, 5, 6, 7, and many more, and so it will indicate that this patient is suffering from the GERD. And after that, just come towards the treatment. In treatment, what you will do, you will ask the patient to do lifestyle modifications, like what were the risk factors: increased weight, pregnancy, etc., etc., or having large meals, or having late night meals. So tell the patient to avoid all these, otherwise we cannot do anything if you do not remain compliant to all of these factors. And after that, what is the treatment? In symptomatic patients, you will start PPIs at full dose. If it is good response, I have told you before, then it continue PPIs at a maintenance dose. If he or she has a poor response, then you will perform what? You will perform the 24-hour pH monitoring. And I have told all of these things in before. So let's just discuss about the pharmacological treatment, that are the PPIs. PPIs and H2 receptor antagonists. Both are responsible for decreasing the HCl production. As there is decreased HCl, there will be decreased reflux, as there is nothing to reflux back, right? So PPIs are the treatment of choice here: omeprazole, lansoprazole, esomeprazole. And H2 receptor antagonists include cimetidine, ranitidine, famotidine, etc. And there are many other drugs like antacid, sucralfate, as well as many more. Here are some other drugs like you can say uh, prokinetic drugs: metoclopramide, domperidone. Cimetidine has some adverse effects like here mentioned. You can remember it from a mnemonic: guilt, 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 though you can also write, and it has anti-androgenic effects. It is just an exaggeration of those anti-androgenic effects. G for gynecomastia, I for impotence, L for loss of libido, T for transient oligospermia. Okay, and after that is the surgical surgery. When you will do surgery, if there is failure of the medical therapy, if someone is unwilling to take long-term PPIs, or non-compliant patient, or if there is Barrett's esophagus, that is very alarming. After that, there is just one option, and that is adenocarcinoma. So you must have to pay attention to this. Here is one more thing, that is last thing that I want to show you, that In surgeries we do fundoplication. Fundoplication is what, like, you just put this fundus portion of the stomach above, or you lift off this portion and you just wrap it around the lower esophagus so that the sphincter tone is somewhat improved or increased. So that was all. Thank you very much.